A special thanks to Professor Jones, who gave me this somewhat poisoned chalice of a topic to present on. So I'm a final year general surgery trainee. I've got my fellowship exams in about 2 months, and I've got the task of standing here in front of potentially some of my examiners in a couple of times to tell them what I can teach them. So the answer to that question is clearly nothing. And I say that a bit tongue-in-cheek, but the thing that I remember when I think about this topic is that all of my supervisors were registrars as well. During their training, they understand the roles of the registrar, the relationships that the registrars have with their supervisors in the hospital. So what can I teach is a hard thing to think that they haven't learnt already themselves. But I guess, you know, times have changed somewhat, so I think there are things clearly that the registrars can teach their supervisors. A couple of things that I want to say firstly is that this is not just about registrars, this is about really anyone in the hospital environment. It might be the residents, it might be the medical students, it might be physios or allied health staff, and certainly the nursing staff, particularly the senior nurses on the wards, are really fundamental in this process some of the time. But I'll keep it to my experience, and so registrars are really the eyes and ears of the consultant, the surgeon in the hospital. We're there all the time, or at least a representative of the registrar team is there pretty much all of the time, whereas obviously the supervising surgeons are not. So there's a major role to play that registrars have in improving patient outcomes, which is what this afternoon is all about. These are my thoughts. There's no statistics here or papers to quote or anything like that. I'm just coming up with some of the ideas that I've had, and I think about this, I have thought about this in preparing this talk, and I think that there are two major categories of areas that that registrars can teach their supervisors about. And one, the clinical issues, surrounding clinical issues, and the other is surrounding system issues. So I'm just going to give a couple of quick examples of cases that were real cases that were at my hospital that didn't necessarily involve me directly. I wasn't the main registrar involved, but they were cases that have happened in the last couple of years that some of my colleagues have been involved with. The first is a patient who had a gastrointestinal perforation, and initially the management plan was to manage the patient with a percutaneous drain. They were stable enough to tolerate that, but over the subsequent 8 to 10 hours that they were waiting for this drainage procedure to happen, they were deteriorating on the ward quite significantly. And the patient was seen by medical staff, and discussions were had, and the plan was in place to treat them with this condition. And the problem was that there was a real failure to escalate when the patient wasn't doing well. Eventually, a more senior registrar came on, saw the patient, said, "This is not right," changed the management plan. The patient ended up going to have a laparotomy, which was the procedure they needed, but subsequently died. And, you know, delayed treatment was a significant part of that. The second example is a slightly different circumstance. A patient presented with an ischemic limb. The registrar who was on call for vascular surgery was actually a general surgical trainee, and was advised in consultation with the vascular surgeon on call to take the patient to theatre. But there was not an adequate appreciation that the general surgical registrar was really not equipped from a skills point of view to do that sort of procedure alone. They ended up, for whatever reason, agreeing to do that. They took the patient to theatre alone. They got themselves into a lot of trouble, and actually had to call an uninvolved surgeon from the next theatre to come and help them to try to bail them out. The patient ended up having a satisfactory outcome, but it's certainly not the way that we aim to do things. So I think these cases highlight a couple of points to do with with clinical issues that where I, as a registrar, can teach my consultant. What can I teach my consultant? What can I teach my supervisor? I can teach my supervisor about the deteriorating patient. I know we've discussed this. This has been discussed a bit this afternoon. I can teach my consultant that I've got a sick patient who's getting sicker. I can teach my supervisor that the treatment plan that we've instituted isn't working and the patient's going backwards. And I can teach the patient, my supervisor, when I need them to intervene. And that requires escalation, obviously. And in my hospital, in our morbidity and mortality meetings at my hospital, I'm sure at every other hospital, it's just such a frequent problem that contributes to poor patient outcomes, is this failure to escalate care in the deteriorating patient. Another thing that I can teach my supervisor is about my limits. The landscape of surgical training is changing, or has changed. I think my experience, my operative experience, my comfort levels with certain operations are very different to the experiences of some of my supervisors. Trainees today get far less operating time and operative exposure. There are a lot of operations that I need to know about for my exam that I have never performed and am unlikely to do before my exam. But next year I'll be expected to perform those unsupervised. And so I need to be able to teach my supervisor that those limits are in place and that I haven't got some of those experiences, and that calling for help is not just something that I will do, but it's something that I should do. In terms of system issues, I wanted to just use another couple of examples of cases. There was a patient who had chronic kidney disease and required some perioperative anticoagulation. The patient ended up being over-anticoagulated because of their renal failure. They got an excessively high dose of clexane, and that ended up causing life-threatening bleeding. They required a laparotomy and went to intensive care, and obviously had it was a very near miss. It turned out afterwards, we found out that the intern in the pre-admission clinic had no access to the anticoagulation guideline, and had they had so, they would have been able to follow the appropriate hospital guideline, which was all correctly written, and they would have been able to identify that that dose of anticoagulation was way too high. There was a patient who had an epidural aneuploidy abscess. The epidural abscess was requiring an MRI to further evaluate and plan treatment. The scan was refused by the radiology department basically because of a clerical administrative problem in how scans are ordered. There was a significant delay to this MRI being completed, and during that time the patient went on to develop a cauda equina syndrome and ended up with permanent neurological change, which is obviously a significant bad outcome. And there was another patient who had ischemic gut and sepsis. They were needing to be transferred in between campuses of the hospital to where intensive care was and where definitive surgery had been planned. The patient arrived in the intensive care unit with no announcement, no notification of that patient's arrival. They sat in intensive care for 6 hours with increasing sepsis and getting sicker, and it had a significant delay to theatre. So these are just some issues, some examples highlighting some of the system failures in hospitals. They're complicated places. A lot of hospitals now operate across a couple of campuses with different services at different campuses, and all of that stuff has to be coordinated. So some of the things that I think as a registrar I can teach my supervisors about the day-to-day working of the hospital include some of these things that I've just talked about, but also junior staff supervision, interns, residents, junior registrars who might be struggling with a workload or might feel out of their depth with the care that they're responsible for providing to patients. And that's a really significant thing that supervisors obviously need to be kept informed of. Another big part of looking after a patient is communicating between the medical staff and the nursing staff. And again, this is something that sometimes there are system failures with the way that communication process happens, and that's something that I can teach my supervisor about shortcomings in that might be contributing to poor patient care. Handover is a well-known time for losing information, important information about a patient, where bad patient outcomes are often attributed to. And the handover process is different in each hospital and is different in each unit, and the processes that happen there is something that I can certainly feed back to my supervisor. And transfers, I mentioned that one between hospital, but also a big one at the moment now with the 4-hour target in emergency departments is that a lot of patients are being transferred to the ward without being assessed by the units, the unit involved, and that process is a critical time in patients who might be borderline patients appropriate for the ward or needing intervention, who really miss out on that opportunity, and it can cause significant delays to treatment or even just the patient's problem being completely missed. And can contribute to obviously bad outcomes again. So they're all things that I can teach my consultant, my supervisor in the hospital. So what do I need to be able to teach my consultant, to be able to teach my supervisor all of these things? And the first thing is the concept of graded assertiveness. This is something that a phrase that I've been introduced to relatively recently, and some of you might be familiar with it, but it's basically a stepwise increase in the level of assertiveness that one person, in this case a registrar, might give to their consultant, but it can be anyone, and basically starting with a gentle inquiry, and if you don't get the response that you need, to step up the level of assertion that you give to that particular problem before the end of it, really assertively saying, we need to stop and reconsider, or whatever it might be, or I need your help, that sort of thing. So that's a very useful thing that certainly at my hospital we're introducing into the registrar orientation. Communication's a two-way process, and as a registrar I can attempt to communicate all these things to teach my supervisor about these various issues, but I need a supervisor who's prepared to listen, and that can sometimes be easier to suggest than it is to actually get in practice, but that's a very important part of the whole process. And finally, for some of these other sort of less acute issues, sometimes in the context of an emergent situation in hospital, some of these system issues can kind of get glossed over, and it's important to have an appropriate forum for feedback from the registrar to be able to go through these things at the end of a term or whenever it might be, to make sure that these things are able to be communicated from the registrar to the supervisors. So thanks very much for your attention.